risk and severity assessment. As we all know that cerebral cavernous malformation is one of the most common intracranial vascular malformations. The disease is characterized by a mulberry-like vascular myocyte shows high intensity of mixed signals like popcorn on MRI. The SY sequence was used to identify the multiple lesions. The incidence rate in the population was 1 out of 500. And the typical clinical presentation was seizure, hemorrhage, and neurological deficit. A CM always accompanied by a DVA, and 19 to 30% of the CCM are located in the brainstem. This is a meta-analysis published in Lancet Neurology in 2016. The study summarized the clinical presentations and the natural histories of the CCM. And the article included 1,620 patients from 6 studies. The mean follow-up time was 3.2 years. The results showed us that the brainstem position is the independent risk factor for CM bleeding or neurological dysfunction. And especially the brainstem CM presenting with hemorrhage or neurological deficit has the highest risk of rehemorrhage. So we need to pay more attention to the brainstem CM. And when we face patients with brainstem CM in practical clinical practice, then how to make clinical decisions is always very difficult. We need to evaluate the natural history risk of future hemorrhage to see whether there's still a chance to observation, and we also need to evaluate the risk of interventional treatment, which includes microsurgery and radiosurgery. We comprehensively compared the risk of conservative treatment and the interventional treatments. Then we may individualize the clinical decisions, which can enable the patients to obtain the best of their quality of life. Then how can we evaluate the natural history of brainstem CM? In 2014, an article published in the GNP journal summarized the related factors of hemorrhage in CCM. The Zabramski classification type 1 and prior symptomatic hemorrhage were significantly associated with the risk of the recurrent bleeding. The Zabramski classification was proposed in 1994, and it remains the most commonly used classification of cavernous malformations. The type 1 means subacute hemorrhage and characterized by hyperintense lesion on T1. So the result means that the lesion with prior hemorrhage were more likely to rupture in the future. However, the risk of hemorrhage from brainstem CM are different from those in other positions. An article published in the GNS journal in last year explored the prospective risk in brainstem CM. The study enrolled 600 patients from 2012 and 2016. 97.3% of the patients has a prior hemorrhage. As a result, a higher risk of future hemorrhage was associated with the presence of DVA crossing midline lesion, hemorrhage on admission, MRS score equal or more than 2 on admission, more superficial location, and the lesion size over 1.5 centimeters. And the right picture is a Zangi diagram. The diagram shows that in patients with conservative treatment as a hematoma observed, the majority of patients' MRI scores will improve. And while if a new bleeding occurs, that may lead to a deterioration of neurological function in some cases. The author also constructs a nomogram based on the above factors, so we can evaluate brainstem CM, the risk of future hemorrhage based on this nomogram. Moving on, another study published in 2014. The study summarized the risk of prospective hemorrhage, but also the neurological outcomes of brainstem CM. The rehemorrhage was associated with prior hemorrhage, which is not surprising, and the prior lesion edema, which suggests that a recent hemorrhage history that matters small. Patients with neurological dysfunction due to prior hemorrhage has the highest annual bleeding risk of 15.9%, and followed by the patients with symptomatic hemorrhage and those without a hemorrhage. Additionally, the study found a 2-year time window for the recovery of neurological function with a recovery rate of 30.3%, and thereafter the rate remained stable. And we think it's important to note that for patients with brainstem CM, we should not only focus on the risk of rehemorrhage. It is critical to emphasize the deterioration of neurological function outcome caused by the rehemorrhage. A study published in Stroke summarized the predictors for the neurological deterioration caused by rehemorrhage in the overall CCMs. The study also confirms that the rehemorrhage risk and the probability of neurological deterioration is higher for brainstem CM than lesions of other positions. And another point of clinical importance is that the rehemorrhage seems to mostly occurs within the first 1 to 2 years after a certain hemorrhage event. It is referred as a temporal clustering with average hemorrhage risk of 2% per month in the first 2 years, and that decreased by fold just after that. This phenomenon, just like a volcano, there will be following activity right after an eruption, and it gradually goes to silence afterwards. Another prospective study on hemorrhage in brainstem CM published also found this phenomenon. However, we think the results of the study is confusing because patients within or without of hemorrhage clustering periods were all enrolled in the study. So patients with high risk and low risk of rehemorrhage were mixed together. We think we should stratify the patients according to post-hemorrhage interval in natural history study. To summarize, current natural history studies are most focused on the brainstem CM, mainly focus the risk of hemorrhage. The risk factors of hemorrhage consistently across 3 cohorts were hemorrhage admission, DVA, and lesion larger than 1.5 centimeters. But actually, not all brainstem CM hemorrhage will lead to a catastrophic and irreversible neurological dysfunction outcome. So we came to think about how to predict the neurological outcome after rehemorrhage for every single patient, and when they come to see us at different time points and with different conditions. Over the past 8 years, we have an increasing number of brainstem CM surgeries at Huashan Hospital, and with a stable of over 60 cases per year. Therefore, based on the Huashan brainstem CM cohorts, we aim to understand the rehemorrhage risk and to explore the specific risk factors to predict a temporal clustering of hemorrhage events. And we want to evaluate the severity of rehemorrhage, which means the neurological function outcome. And the last, we need to weight the risk of natural history versus interventional treatments. Our study included 123 brainstem CM patients confirmed by MR in Huashan Hospital from January 2015 to March 2022. We identified brainstem CM patients with a diagnosis of hemorrhage based on clinical symptoms and of imaging evidence. To minimize the impact of intervention on natural history observation, we only enrolled the patients who had an interventional treatment-free follow-up period over 12 months after the symptomatic hemorrhage or subsequent hemorrhage during the interventional treatment-free follow-up period. The focus of our study was on the risk of rebleeding and changes in neurological function in patients within 1 year after their first hemorrhage. The overall hemorrhage rate within 1 year after prior hemorrhage was 36.6% with an average of 3% per month. The result is a bit higher than previous studies. The median time of recurrent bleeding was 9.1 months. After addressing the factors such as age, gender, neurological function status, multiple lesions, brainstem location, lesion size, crossing the axial midpoint, and the related DVE, we found the predictive factors were prior hemorrhage times and Zabramski type 1 of 5. As the Zabramski type 1 means a subacute hemorrhage, so our results were consistent with previous studies. And we then screened the clinical and imaging features through lateral regression to reduce the potential multicollinearity among variables, and selected features were further verified and modeled through logical regression or ordered regression models. We found that 34.5% of patients experience neurological disabled immediately after their first bleeding. The overproportion of neurological deterioration after rebleeding was 46.4%, with a mortality rate of 1.2%. The Zabramski type 1 of 5, medullary or midbrain and multiple CCM were associated with worsening clinical status. However, the number of previous bleeding times was not an independent predictor of worsening neurological function. And this is another lateral regression and to determine the high risk factor of neurological deterioration. And for each patient, the probability of rehemorrhage within 1 year can be estimated using a nomogram based on prior hemorrhage times, Zabramski 1 of 5. In addition, the risk of neurological outcomes can be evaluated by previous MR score, whether it is multiple, and the medullary midbrain location. The calibration curve of the nomogram had a good discrimination with an accuracy of 80% for predicting the hemorrhage and accuracy of 71% for predicting the neurological status after rehemorrhage. And if we face a patient and we can use this nomogram to predict the subsequent hemorrhage and the neurological status. It's a patient, 30 years old male, and referred to our clinic with onset of dizziness, nausea, and left facial numbness. The MRI scores was 2, and T1 and T2 images shows a pointing cavernous malformation. Use our nomogram and the subsequent hemorrhage has 15% possibility, and the patient has 40% to be worse than now, and 55% to remain the same MRI score. The patient, after 16 months follow-up, the patient was brought to the emergency department because of severe nausea, vomiting, and vertigo. The MRI was 3, and the MRI confirmed his second hemorrhage with distinct false ventricular compression. Considering a significantly increased risk for subsequent hemorrhage clustering, the patient underwent surgical treatment. However, we think simply assessing the risk of hemorrhage or neurological dysfunction cannot determine the clinical decision of the patient. Based on their evaluation results, we can find the patients who may experience the morbidity and require early intervention. But then we need to compare the risk of conservative and interventional treatment to develop a personalized treatment plans to achieve the best quality of life for patients. Now let's talk about the available treatment options. Microsurgery is an important treatment of brainstem CM, and there are several post-operative outcomes prediction symptoms available. Professor Lawton's model, which was published in Neurosurgery in 2015, is the most widely used system. It is based on the surgical outcome of 104 patients undergoing surgery, and constructs a 7-level score based on factors such as lesion size, midline crossing, DVA age, and hematoma time. This is another study to be external validation, and the prediction accuracy of this model were high, and the outcome of patients in grade 6 to 7 was very poor, and this was very unacceptable for patients. Moving on, some studies on radiation therapy for brainstem CM have been published, and the results shows that 2 years after gamma knife treatment, the risk of bleeding in patients is significantly reduced. However, due to a peak of rebleeding in brainstem CM occurring within 2 years, gamma knife treatment is not efficient to reduce the risk of early bleeding. Therefore, the radiation therapy is only recommended for those patients with high risk of hemorrhage and poor surgery outcomes. Moreover, LITT has been early applied in the ablation of intracranial epileptic foci and the treatment of thalamic gliomas, and its efficiency has been confirmed. In recent years, many supratentorial CM have also been treated with LITT to reduce the risk of epilepsy. There are also studies exploring the effectiveness of LITT in BSCM MCM, but due to the small numbers of cases, the therapeutic effect is currently uncertain. In the future, there may be more studies to explore the role of LITT in brainstem CM. To sum up, we have proposed a predictive model to individualize the evaluation of the risk of rehemorrhage and the neurological outcomes of brainstem CM. Identification of the patients with warning bleeding can help to perform active intervention to and in order to prevent potential morbidity. And we suggest to apply more standard tools to design personalized treatments for patients and achieve the best quality of life. Thank you for your attention.
Okay, thank you, Dr. Li. Actually, I think you talk about the rehemorrhage for the brainstem cavernous malformation, and you have a large series. I saw it's over 700 brainstem cavernous malformation, right? And there are about 300 cases in your hospital got surgery, and the other 400 or 500 cases they don't have surgery and still were observed, right?
Yes, Professor. We have over 284 surgeries in past 8 years, and we think the numbers are very high and in the whole world.
Okay, my question is about for those cases got surgery. I mean, is there any chance for rehemorrhage, rebleeding after the first surgery?
Yeah, in this of 280 cases, we have already do the follow-up, and we found about 4 to 5 patients had a rehemorrhage, and they had their MRI and confirmed their recurrent CM. Maybe the last surgery, we did not resect the whole lesion.
Okay, yeah.
Okay, we have a question, Wan Li. Go ahead, Wan Li.
Sure, yeah. Oh, who want to ask question?
Yeah.
I would like to ask a question.
Go ahead.
Yeah, there was a very thoughtful analysis, which was excellent for brainstem. But I wonder, what is the risk of neurological deficit after the rupture of hemispheric cavernoma? I was unable to find any data on that. The risk of neurological deficit after rupture of hemispheric cavernoma.
Yeah. So I think there are 30 points percent of person in rehemorrhage patients may experience neurological deficit. That means their neurological function was a deterioration.
Is that okay, Vlad?
Yeah. Okay, by me.
You seem like you're not sure, Vlad. Is there anything else you want to?
You know, it's obvious that you have some neurological deficit after the rupture of the brainstem cavernoma, because all the structures are packed there, everything is highly eloquent, and it's just logical that half of the patients at least, which is somehow surprisingly low number, have a neurological deterioration after the bleeding. But nowhere was I able to find this figure for hemispheric cavernomas, for those in frontal lobe, in parietal lobe, even in cerebellum. We only know about the risk of rupture, but the risk of rupture is not the same as the risk of neurological deficit.
Okay.
Yeah, I
get
think your question is about I think Dr. Lee just focused on the brainstem cavernous.
Right.
cavernous
It was just a question
formation.
whether he doesn't know anything about that, you know.
Oh,
I'm just curious.
okay, yeah. I think for my opinion, most of the cavernous malformation, if they're in like frontal, parietal, occipital lobe, there's even with rebleeding, maybe still no new symptoms. I guess it's not like aneurysm or arterial venous malformation. Even for the cavernoma, even rebleeding, maybe there's still very like small bleeding. So the lesion enlarge slowly, and so in our hospital, I saw some patient with like 1 centimeter, 2 centimeter, even some case maybe larger than 2 centimeter, but still no new symptoms. So yeah, I'm not sure why. I guess it's because it's a repeat bleeding, but every time only 1 millimeter. So yeah, I don't.
It's harmless, actually. Yeah, we did a big meta-analysis which was published in the Journal of Neurology, Neurosurgery, and Psychiatry, which surprisingly you didn't mention in the lecture. And the natural course is not very much altered by the treatment in hemispheric cavernomas. It means that it's really questionable we should be operating on them unless they produce epilepsy or unless the bleeding is large, because we really do not change the natural course too much. But we have only number, as you said, in AVM, we know the risk of bleeding and we know the risk of morbidity mortality, both from Aruba and other studies. But we do not know this risk of morbidity mortality in hemispheric cavernomas. And that's what I'm hitting at. We probably do offer surgery to patients which do not need any.
Yeah, I agree. Yeah, maybe only for those patients with a seizure attack.
Right.
Yeah.
Right.
Okay, I agree with you. Yeah, thank you.
Thank you.
Okay, well, let's move on to a question with Takashi Kan, neurosurgeon from Tokyo. Are you there, Takashi?
Yeah, thank you for a very informative lecture. And cavernous angioma, brainstem cavernous angioma is very difficult to treat. And I'm interested in the LITT, efficacy of LITT, laser interstitial thermotherapy. So you will cause usually perifocal edema and getting the deterioration symptoms. Do you have some experience to avoid those complications with the LITT? Sometimes expecting the efficacy of LITT.
We have done one case of LITT treatment of supratentorial CM, but we haven't done such a surgery in brainstem cavernous malformations. And really, we see the post-operative perilesion edema, and after the surgery, we always relieve the intracranial pressure and use some medication, and almostly the patients have a median symptom, not very serious condition. Yeah.
Thank you.
Thank you.
Okay, Wan Lee?
Yeah, okay, yeah, I'm here.
Okay.
There's no more question, right?
I don't see
Okay.
any. I guess we can close,
yeah.
Wan Lee.
Maybe, yeah, I think we should finish here. So thank you
Okay.
again, Dr. Lee. Thank you, Dr. Caldwell. I guess, yeah, today we have two nice talk. And thank you everyone for your listening.
Very
Okay.
good.
I
Thank you, Wan. Yeah, thanks, Wan Lee, for setting that up
Thank
and
you.
everything. Thank you very much for the last of the speakers, and it was great interaction. Thanks for coming, Vlad, Ahmad, Ibrahima, Mohammed, Helmi, Omar, and I don't know if William Caldwell's still listening. And we'll see you in 2 weeks.
Okay. See you.
Okay.